Call to order this regular July meeting of the Panhandle Health District number 1, 5 northern counties of northern Idaho. Words are important. I have called this meeting to order. As long as there is order, we will have a meeting. At any point there is not order, there will not be a continued meeting. I will call roll just so you know who our board is. Beginning from home, Boundary County Commissioner Walt Kirby.
Mr. Chairman, I don't have any video of you guys.
Thank you. From Bonner County, Glenn Bailey, former county commissioner and Bonner County representative.
Present.
Dr. Alan Banks, our at-large member living in Bonner County.
I'm here, Mr. Chairman.
From Kootenai County, Jay Nelson, former county commissioner and Kootenai County appointed member to this board.
Present.
Dr. Richard McLandris, our medical consultant, also from Kootenai County.
There, sir.
From Shoshone County, Mike Fitzgerald, County Commissioner. My name is Marlo Thompson. I represent Benoit County and I am a county appointed member to this board. At this time, I would ask you to stand as we pledge allegiance to the flag. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation under God, indivisible, with liberty and justice for all. Thank you, and you may be seated. We will now move into our public comment session, and to read our position is our legal counsel, Mr. Mark Lyon. I will give the floor to Mr. Lyon.
Thank you, Mr. Chairman. I want to lay out some of the public meeting guidelines for this meeting. First of all, as you probably all know, but let's check it anyway, please silence your cell phones. Secondly, it's worth noting that the board has already received, the Board of Health has already received many, many comments on agenda item 5 and the issue of masking. Now, this is the public comments section of this agenda. And I want to remind everyone that these Panhandle Board of Health meetings are business meetings for the Board of Health. The meetings are not a meeting with the public. While these meetings are open to the public, that means that the meetings take place in a public setting where members of the public can participate at some level, watch and hear. Although not required to do so, the Panhandle Board of Health allows a limited opportunity for members of the public to provide comment on issues related to items on the agenda. Comment at board meetings are subject to the discretion of the board chair at all times. Persons wishing to comment should have filled out a comment card in advance of the meeting. If you choose, you can submit written comments in lieu of speaking. Those comment cards will be included in the board records. Verbal comments are limited to 2 minutes and must be related to an agenda subject. There is a timer, and the commenters will get notice when they have 15 seconds remaining. So wrap up quickly if you get that notice. Keep in mind that comments should not be unnecessarily repetitious, and of course, the comments should not be disrespectful or disruptive. The comment section of the agenda is limited to 20 minutes in total. When you are asked to comment, when your name is called, please come up to the podium, state your name first, and then your comment. If you feel you've got comments that are similar to others, if people outside this room are listening, you may consider picking one person as a spokesperson to address your shared thoughts. You might also think again about choosing to leave written comment. Finally, comma, I tend to talk that way because I dictate a lot. Finally, the board will not hear comments regarding the performance by or complaints about specific district employees or other representatives. These types of comments are never appropriate in a public meeting and should be addressed to the appropriate administrator or director outside of a public meeting. So those are all the comments. I think you know the rules heading in, so let's everyone be respectful and have a good meeting. Thank you. Chairman?
Thank you, Mr. Lyons. I have several pages, these blue pages on which are names. I am going to read just the first name, and as I call your name, and if you think that's your name, please come to the podium and make your comment. These are not necessarily in the order that they have been received. Do we have a Chris in the audience? Yes, sir. Please come. By the way, I will introduce to you Jamie Barton over here to my right, to your left, is our timekeeper.
Okay, thank you. I appreciate the opportunity to make a comment. You guys are health professionals, and I think you know how smells get into our nose and our nasal cavities. I don't think I have to explain it for you, but for the purpose of those listening, we know that happens by little particles of whatever we're smelling getting into our nose, actually. It is proven in multiple studies from back as far as 2009 from British Medical Journal and other medical journals and medical studies that masks cannot, particularly cloth masks, paper masks, are not able to fully keep those particles out by evidence of the fact that you can actually smell things through them. And I've worn masks just like you're wearing there in construction and can smell things through those as well. Science has proven that that's true, and so I think that in consideration of that, and in consideration of the fact that as the mask mandates have happened in Washington, California, and New York, the COVID cases have actually risen, not gone down. They've risen exponentially. I ask a question and I have a comment. How is wearing a layer of paper and material through which particles can still enter and exit the nasal cavities going to do anything or other than further divide the people? Some of us, like myself, even in spite of wearing masks, have had chronic coughs for over 20 years. According to all the signs that you guys have put out, I can't go into any stores with that. So that means I can't go grocery shopping for my wife who's pregnant. I can't, and that's, I feel like that's actually a little bit discriminatory, so I would ask that we not have a mask mandate. That would be my request. Thank you.
All right, could you give us your full name and your county of residence for the record?
Yes, my full name is Christopher Dortignac. My county of residence is Kootenai.
Thank you.
Thank you.
Savannah?
Hi. Savannah Bupert, Kootenai County. Well, good afternoon, ladies and gentlemen, and thank you for the opportunity to speak and voice my concerns against mandatory masks. Thomas Jefferson once said, "All tyranny needs to gain a foothold is for people of good conscience to remain silent." It is the role of a civil servant to listen to the desires of his people, not to make rules based on personal opinion. The government was intended to be controlled by the people, not to control the people. Mandating what we can and cannot put on our own bodies is a violation of civil servitude and the oath of office. Treating your citizens as petulant children you must force into obedience instead of capable, free-thinking individuals is not only insulting, but unconstitutional. We have the right, as free citizens, to take matters of health into our own hands, exercising precautions as we see fit. We shall not be punished for having a differing opinion to that of the government. For the common good and for the health of the nation are dangerous phrases we have heard repeated again and again in defense of mandatory masks. Hitler, Mao, Stalin, Castro, Franco, nearly every dictator one can think of has also advocated or purported to advance their ideas for the common good. Last I checked, we are a constitutional republic, not a dictatorship. We are not California, we are not New York, we are not Washington, we are Idaho, and we are making our voices heard. To you, our civil servant. Thank you.
Yes.
Can I interrupt for a minute? The process that we're having here is that as a speaker comments, then they leave the room because we have a lineup of people that want to come in, many of whom want to comment. So we'll continue that process for the 20-minute time frame that we spoke about before. Thank you, Mr. Speaker.
Let's go to one of our elected officials. Ron? Granted. And who, where is, yes, sir, you have the floor.
I would like to wait until my turn.
Okay. You understand, he is yielding and you don't want to use your time right now, is that right?
I want to maintain the same order of speakers as you have already indicated, sir.
I have no order of speakers. I am picking at random. How about Summer?
Summer Bushnell, Kootenai County resident. I had a question before I start. Can I ask a yes or no question and get an answer? Is that not part of the decorum?
You may speak and we listen.
So you won't respond? Okay.
That is correct. We do not
When I ask questions,
respond.
it'll be rhetorical. Okay, just want to understand. Okay, so from what I can tell, health districts like Panhandle Health track sexually transmitted diseases, right? From what I can tell from what I've read online. And education on sexually transmitted diseases is how people are encouraged to protect themselves, right? It's a behavior. Does Panhandle Health have the power to stop people from having sex? They do not. If Panhandle Health does not have the legal power to stop people from having sex, why are you guys considering telling me what else to do with my body? Do you have the power to make me wear a yellow star on my shirt? No, just like you can't tell me how to dress, you can't tell me who I can have sexual relations with. So from my perspective, you're violating local residents in the 5 counties' rights to life, liberty, and the religious rights. This seems to be a slippery slope because this is making it so people can't buy or sell without a mask or a mark. I strongly encourage you to do education and not mandates. Thank you.
Ted? Do we have a Ted? I believe this is a Ted Grafton.
Ted Grafton.
Ted Grafton?
Sorry about that, I didn't bring my hearing aids. Before we start my time, I'd like to make a comment.
Could you state your name and the
Oh.
county you represent?
My name is Ted Grafton, and what I represent?
County?
Bonner County, I'm sorry. I'd like to thank the law officers who are here doing their job, and I think if we didn't have law enforcement, we would not be having this peaceful rally we're having right now. With that all said, we the people of the United States, in order to form a more perfect union, establish justice, ensure domestic tranquility, provide for the common defense, promote the general welfare, and secure the blessings of liberty to ourselves and do ordain and establish this Constitution of the United States. We hold these truths to be self-evident, that all men are created equal, that they are endowed by their Creator with certain unalienable rights, that among these are life, liberty, and the pursuit of happiness. Kind of nervous. That's and I'd like to read to you. Let not mercy and truth forsake you. Bind them around your neck, write them on the tablet of your heart, and so find favor in the high esteem in the sight of God and man. Trust in the Lord with all your heart. Lean not on your own understanding. In all your ways acknowledge him, and he shall direct your paths. When the President of the United States said, "We are fighting an invisible enemy," the enemy is not COVID-19 or monetary masks. It is those who are trying to destroy the United States of America and our Constitution and the Declaration of Independence.
Thank you. Your time has expired.
Yes, it was quick.
Is there a Tim? I believe the last name is Remington.
Yeah, I would also, with Representative Middive, like to give our time so we do not repeat ourselves to
Thank you.
Representative Wisniewski.
Thank you. All right. Is there a Pamela here? Pamela?
My name is Pam Nordby. I am a Kootenai County resident since I double bagged for this occasion, so I don't like wearing a mask, but as a child I had polio. I was in a iron lung for about 6 months, paralyzed from my neck down.
Is this microphone not projecting? The red light is on.
You got a mask on, Marlo.
Does that help?
Marlo, the green light should be on for your
Yeah.
Green or red?
Red light should be off. There you go.
Is it on now? They keep telling me which light to look for. Keep in mind that I'm colorblind.
That should be good.
All right, can you hear this?
I can hear you talking, sir, but the microphone is not working.
You don't have a red light right here.
Test.
Test.
Does that work? Does this work? I apologize for the delay. We will have time for 4 more people to comment, and then we will have to close the public comment session. We have gone beyond our 20 minutes, but we recognize the importance of this. So we will call on 4 more people. Harry?
Hello, Mr. Chairman. We spoke the other day.
Yes.
Good to finally meet you. Basically, I want to talk about, is there a pandemic? Because none of us would be here without that. And really what it is we can't know if there is a pandemic, because we don't have any accurate numbers. We can't get accurate numbers. We have people who are showing up positive for COVID that never even been tested. We have a bounty, a federal bounty being paid to hospitals of approximately $33,000 for a patient. We have approximately $1,300 bounty being paid to some local jurisdiction if there's a positive test. And we have all kinds of information, misinformation, so we don't even know if there's a pandemic, because the flu is numerically quite similar to what we are seeing now. And so that's one issue. Another issue is, can the governor do what the governor did? And unfortunately, in spite of his very good staff, he can't read because words have meanings. And words have meanings in law, and the law usually starts, a chapter usually starts with definitions. Isolation and quarantine are powers that the governor does have of those that are infected or suspected. That is the end of his power. There's no power to impose quarantine or isolation on the population as a whole. That's a complete breach on his part. And so we can't move forward knowing what there is for a pandemic, and masks, a mask mandate can't happen. And with that, Mr. Chairman, I yield. Thank you.
Thank you. This gentleman is from Benoit County. Do we have here a Patrice?
Hello, my name is Patrice Barnes, and I'm from Kootenai County. There's a couple of things about this masking that I've been very concerned about. I carry a firearm, and according to law, it says that we're not allowed to have a mask on while we're carrying. So, in other words, you're taking away my Second Amendment rights by making me wear a mask. So, that's wrong. Second, who's going to enforce this? The sheriff has already said that they're not going to enforce this law. So, the law is unenforceable. So, why are we even here? Third, just today, there was a fishing trawler that came in off of the Argentine coast. All of the crew members of this trawler were quarantined for 14 days, and they all tested negative for COVID. Within 23 days, they ended up having symptoms for COVID. So there you go, folks. That's the way it is. So science doesn't really know. What I think we should do is just do a herd thing and just go ahead and unmask. Don't be afraid, and everybody's going to get through this okay. And we've only had one death in Kootenai County. Thank you.
James?
Steamers?
Yes.
Did you get a chance to speak yet, Pastor? Hi. My name is James Seamers. I live in Priest River, so I am in Bonner County. I know that this does not affect me now, but if a mandate happens, it will affect all of us here. And even mandates that are happening in other states are affecting us here, obviously. What I was here to talk to you about today is mostly about fear. We are being governed by fear right now, by a fear of something that we cannot see. Even our president has called us an invisible enemy many times in the beginning. And I want to give you an example of what fear is like. So yesterday I was at a physical therapy appointment. I do not wear a mask when I'm in public because I have a medical condition that does not allow me to breathe with one, especially an N95 mask, because those inhibit your ability to get oxygen. You expel CO2, you also intake CO2. So when I'm taking physical therapy, and I have to work my body out to try and get myself better in an environment where they are distancing, and they're doing that, it's harder for me. I witnessed a woman come in that was defending her mother yesterday, saying that she had been in the facility in which she was trying to get her physical therapy. She had an N95 mask on, she was on a bike, and she started to get a nosebleed because she wasn't getting enough oxygen into her body. And her daughter voiced that concern to the medical carrier. I don't want to put them on blast, but I witnessed this, and I heard her say that basically one of the carriers said, well, we could adjust, she can still work out, but we can adjust how much she's doing, however, she still has to wear this mask. And to me, that showed me that this woman had an existing medical condition that did not allow her to wear the mask. And these people in fear right now, you see people driving around in cars that have these masks on that are restricting their oxygen intake because of fear, not because of facts. Because the media has lied to us for a very long time, we all know it. People are wearing them because of fear, not because of fact. You guys have heard this gentleman come up here with the mask and he was talking about it. And I know that my time is done. I appreciate you guys, but just remember that literally people are watching the Clinton News Network, watching the death counter all day, sitting in front of a TV because they have existing medical conditions and they have a reason to be fearful. However, when you wear a mask like an N95 like that for long periods, you put yourself at risk because you are yourself making yourself being deoxygenated. You are causing your own harm to yourself.
Your time is up, sir.
And I thank you for allowing me in. I just wanted you guys to remember that. This mandate, if it is passed, is not legal and it's not constitutional. Thank you.
Dawn? D-A-W-N?
Letting us talk.
State your name and
Dawn
county.
Antrim. I'm from Coeur d'Alene.
Kootenai County.
Kootenai County, yes. 3 years ago, I was diagnosed with an autoimmune disease, and it affects my lungs and my brain. And certain things will trigger it. It can be something I eat. It can be somebody's perfume or cleaning or welding. Anything can affect it, and it really makes me really sick. But my point is, that's my responsibility. It's my job to take care of myself. It's not me to tell you to quit welding or me to tell you to not use that cleaner around me. It's my job to take care of me the best way I see fit, just like I need to take care of my kids. So I think when people are telling us that we're not compassionate enough, that we don't care about other people's health, that's not true. We just need to be responsible and take care of ourselves. Best way we see fit. Thank you.
We'll take one more. Shannon?
My name is Shannon Edwards, and I'm a Kootenai County resident. And I want to thank you to the law enforcement for keeping the event nice and calm. I was born with my medical condition. I cannot wear a mask because if I do, I will die from it. I don't have the normal run that everyone else has to get able to oxygenate properly. If you force me to wear a mask, I can't go to the store and get what I need. I can't be a caregiver to my mom who is elderly, who also can't wear a mask. I really don't think we need to have a mandate. If you want to wear a mask, go ahead and do it, but don't force me as a medical citizen to wear one. Also, as per Indian law, I can't wear one anyway because I'm hearing impaired, and if I wear one, it prevents me from hearing what the person is telling me. So you are already violating my Indian law for forcing me to wear a mask. And this is Idaho. If you force me to wear a mask, I can't carry, and I can't protect myself. So, thank you, and I really would hope that you vote no on this mandate. Thank you.
This will conclude our public comment session. We are keeping all of the comments that you have written. These will be looked at by our staff. All right, we will move on with our agenda. This is item 3. If you have an agenda, we will move on now to item number 4, which is
We were the third and fourth people here today. We've let many people in. Since we have been in here even, and we were both signed up to speak. There are pastors and...
Well, I'm sorry, people. There was no way we could have everyone speak, and you are out of order. So just please be seated. You are welcome to write your public comment.
We were in line.
So there were a lot of people in line.
Now I think so, maybe.
But this is the one I was using.
And he took 6 or more minutes.
No, I don't. How do I get that red light back
Needs to
on?
be on.
How do I get this back on?
Mine, people hear me.
All right, I call the meeting back to order. Thank you. We will come back to order. We will come back to order. Lady, you are out of order. You are out of order.
I was following your rules. Totally unfair. Totally.
There's no way we are going to be able to please everyone, and we recognize that. We will do our best. I apologize if we don't hit everybody's bat. We will continue with the meeting, and the next item on our agenda is our consent agenda, which consists of the minutes of our last meeting, which was May 28th, and July 7 and July 17. There are the divisional reports in the public comment session, in the consent agenda, I'm sorry, and then we are approving or speaking otherwise on a number of contracts, and this consists of our consent agenda. Is there any item on the consent agenda you wish to pull for further discussion? I will entertain the motion if you so wish to make. Mike?
Mr. Chairman,
Oh, I'm sorry.
I move that we approve the consent agenda.
All right.
Second, Mr. Chairman.
It was moved not by Mike, but by Alan Banks, and it was seconded by Dr. McLandris. Is there any other discussion on this motion that we approve the consent agenda as presented in our packet? All in favor then of approving the consent agenda indicate by saying aye.
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 Opposed, no. And it's so ordered. Thank you. Moving on, I will take this time right now to introduce our director, Laura, who will make some introductions for our next speakers. Laura.
Mr. Chairman, thank you. Can you hear me? No. Some difficulty with this mic, I apologize. Our next agenda item is hospital capacity related to COVID-19 at Kootenai Health. Bonner General Hospital was unable to be here, so we'll be hearing from the CEO of Kootenai Health, John Ness. I've known John since 2010. He has been at the helm of Kootenai Health. He's going to make some opening remarks, followed by Jeremy Evans, who is the Executive Vice President and regional and hospital operations. He's been with Kootenai Health for 12 years, and he's currently serving as our COVID incident commander. Mr. Ness.
Thank you, Laura. Good afternoon, and thank you to the Panhandle Health District Board and leadership for all of your efforts. The role and responsibilities of public health have never been more important, nor have they been more challenging than they are today. So on behalf of Kootenai Health and our board, we appreciate all of your efforts. So my comments today are not specifically related to masks. The issue at hand is larger than that. So instead, I intend to provide just a high-level narrative assessment of our community and regional COVID-19 situation. And then I'm going to ask Jeremy Evans, he's got a PowerPoint presentation on our capacity at Kootenai Health. And then I just have some closing comments. So let's back up. Let's start at the beginning of this situation. So on March 11th, the World Health Organization declared a pandemic. The comments at that time were, "We have never before seen a pandemic sparked by a coronavirus." Let that sink in. Their other comment was, "And we have never before seen a pandemic that can be controlled until a proven vaccine is universally available." We have a problem. So in the state of Idaho, our governor and leadership announced a 4-stage reopening plan on April 23rd. And we have moved all the way from stage 1 to stage 4 by the end of June 26th. So we moved very quickly through that process. During the month of June, as happens often in our community in the summer, there were a significant number of community activities and events that occurred. So here's what occurred after that in terms of coronavirus positive test results. By July 6th, Kootenai Health had 3 hospitalized patients and a total of 420 positive test results in our drive-through testing center. 1 week later, we had 8 hospitalized patients and the total positive test results had risen to 718. 1 week after that, we had 19 patients in the hospital and 1,022 positive test results. As of this morning at 7 a.m., we had 26 COVID-19 patients in the hospital and 4 deaths. You can see where this is going.
John, if I could ask Lynn Bailey. John, you mentioned that there were 4 deaths attributed specifically to COVID.
Yes.
Okay, what were the ages of those individuals?
Yeah, I'm not going to share that today. We can make that available at a later time.
Okay, well, that's information that is useful.
Okay, thank you. So let's keep talking about the story of what has transpired. Why has our situation worsened so quickly? What happened? So one of the cultural attributes of North Idaho is a sense of independence and even pride in our individual rights of freedom and personal choice. Some might say that we value independence and freedom above all else. That is the most important thing to all of us.
And common sense.
Number 2, we are also a very friendly community and region, and we are very attractive to visitors and guests interested in enjoying our amenities. We are a destination for many people from other states, especially in the summer months. So, while Idaho remains open, the states of Washington and Montana have masking mandates and other restrictions in place. So we are experiencing large numbers of out-of-state visitors. our limited restrictions may be contributing to our situation. At the same time, we have a high number of vulnerable seniors in our community, and we are at risk in our long-term care facilities of becoming a hotspot. And local schools plan to open in a matter of weeks. So all of these attributes are making the risk of COVID-19 spread difficult to manage, and they make the responsibilities of public health a real challenge. Plus, it appears likely that we are going to be in this situation for at least 6 months, if not over a year. Based upon the current situation, our collective efforts need to be on slowing the spread of COVID-19 to protect each other and to ensure that we have the health care capacity to treat all patients, not just COVID-19 patients. So I'm going to stop there and ask my colleague Jeremy to give you an update on hospital capacity.
You have the floor.
Thank you. Do we have the ability to show the slides? Thank you. Thanks for inviting us. We're happy to be here to share our experience. I hope that we're able to tell a little bit of a story here today. Go ahead and advance a slide. And maybe 2 slides. Those were John's introductory comments. Okay, this is really just an illustration. It is a graphic that we put together to try to help frame this conversation. So the bubbles, if you will, the circles on this diagram really represent the demands, the elements that the COVID crisis has put on your health system. And remember that all of this demand from COVID sits on top of what I would call the normal, necessary healthcare needs of our community, right? It's above and beyond. So let me try to talk you through just from a high level. The largest blue circle is COVID testing. We set up a testing center in May, and it was back in March. And to date, we have tested almost 22,000 individuals through that center. Okay? These are physician-ordered tests, people who are experiencing symptoms or exposures to COVID. Of those 22,000 tests that have been performed, about 5% of them, 1,125, have come back positive for the COVID virus. Of those 1,125, most, as you know, take care of themselves at home or in an outpatient setting. That's that green bubble, right? About 1,060 of those individuals. I'm not going to talk a lot about that bubble because that's not a high resource intensive means of care, right? Now you do need to know that our urgent care centers, our physician offices are all experiencing high volumes, high frequency of phone calls from the worried well, from folks who have symptoms who just don't know what to do. So there is demand in that outpatient setting. Back to the positive cases. Of the 1,125 to date through the pandemic, 65 of those individuals have been admitted to the hospital, okay? About 5%. And these percentages are pretty representative of what the entire nation is experiencing. Of those inpatient admissions, about 1 to 2% require critical care services within the hospital. And all of this requires extensive resources from staff, supplies, and equipment. So I'm going to go into a little bit greater depth on those blue circles and maybe on the resources, and then conclude with some summary points. So go ahead and advance the slide. So let's start with testing. Again, back in March, we stood up our 2207 Ironwood Place Testing Center. It's a drive-through. We are able to swab patients in their car and collect those specimens. You can see that for the first several months, we are averaging about 100 to 120 tests per day. Over the past 3 to 4 weeks, that average has increased to 400 tests per day. And I think our record is upwards of 733 tests in one day. So a lot of volume through there. We've done a good job staffing that site, expanding hours, managing traffic, and a variety of other things to meet the testing demand of the community. If you flip to the next page. Of those 22,000 tests that we have performed, 4.9 of those have come back positive. And you can see the positive results over time. So again, over the last 3 to 4 months, the positive tests have certainly spiked, and to date we have approximately 1,000, 1,050, 1,100 positive cases. Okay? You can see over the last 7 days, the percent positive test is 8.7 of those that we collect. That number has gone up. Okay? Let's go to the next slide, please. So let's talk about the hospital inpatient capacity. Now this is, in general, total capacity for the hospital. We are licensed for 331 beds. Now many of those beds are specialized. They're specialized for behavioral health, for obstetrics, neonatal intensive care, pediatrics, and the number of beds that are available for general medical, surgical, critical care patients is 190. And on average, to date, not just through COVID, but historically, we run at about 80 to 85% capacity of those 190 beds. Okay? Our critical care unit has a total of 26 beds. On any typical day, 22 to 24 of those are occupied by, again, the necessary normal experience we have in healthcare in this community. These are folks who have had heart attacks or cardiac surgery, who require neurosurgery, who have significant trauma. These are high acuity patients, okay? Our ability to serve a surge of COVID patients requires us to balance this in our ability to serve the normal necessary healthcare of the community. It requires us to flex down at times. As you know, in March and April, per CDC guidelines and others, we ceased all elective surgical procedures and limited our services to only emergent necessary cases. This was across the whole country, hospitals were doing this. That created a backlog of demand, right? When we defer cases, the healthcare needs still exist in the community. To date, we've been able to complete about 66% of that backlog, but there's still a third of those folks who have yet to be scheduled or those cases performed. Next slide, please. So let's talk about COVID. Again, to date, we've had 65 inpatient COVID admissions. 2/3 of these have been in the last 3 weeks. 13 of those 65 have been admitted to our critical care unit. And today, July 23rd, we have 26 COVID inpatients, and 5 of those require critical care. We've certainly developed plans to expand our inpatient and CCU capacity, but again, in addition to additional staffing, equipment, supplies, it requires us to begin to look at how we can accommodate that additional volume and what services can we begin to diminish. So it's a big challenge, it's a balancing act. Okay, next slide. So we have a plan. This is our plan. We call it Kootenai Health Forward. Hard to read this slide, but it is a plan that you can dial up and dial down based upon the volume and needs and supplies and resources in the community. When we started back in March and April, we were at level 1, that red category, and we ceased all elective surgery, all elective procedures. We advanced into level 2 where we began to reintroduce some of those services, and we are currently at level 3 where we are trying to catch up on the backlog of all of those services that we have deferred. We were approaching level 4, which would be, in essence, the new normal, and opening up our services in full capacity until the recent 3 to 4 weeks where we've seen this surge of coronavirus patients. And so now we are actually looking back towards level 2. The threshold for inpatients between level 3 and level 2 for us is 32 inpatients. Again, today we have 26. And what we have found is that as we approach 20 or more, we have to get very creative with how we manage our resources and reallocate our staff and balance the inpatient needs throughout the hospital. We're estimating that our top-end capacity for COVID patients, which would put us right back into that level 1, would be around 93. So you can see we're at a tipping point for this first stage. If the coronavirus continues to grow, we may need to start reducing elective non-COVID services for our community. which we really don't want to do. Next slide, please. So how does this look throughout the region? The table there shows eastern Washington, and you can see those hospitals are experiencing similar volumes than we are. In addition, the hospitals in the 10 northern counties, now this would be District 1 and District 2, have been working together to develop a capacity management plan. In many cases, the critical access hospitals, which are small, they only have 25 beds in total, are able to take a few of the lower acuity patients, but Kootenai Health remains the critical care hub. We are the only provider in North Idaho who has the depth of a critical care unit with board-certified intensivists and credentialed nursing staff to care for complex critical care patients. I also wanted to mention the long-term care community because this is also really critical to this puzzle. Likewise, these long-term care facilities are collaborating and trying to figure out how they can serve the community, but many of them have identified a strategy for which when their residents or their patients, if they test positive, that they will no longer care for them or they'll ask them to be dismissed from their services. And that presents a tremendous challenge for Kootenai Health because these folks end up on our doorstep in our emergency room. They may not have the medical necessity or the meet admission criteria for a hospital, but there's no place else for them to go. And they occupy some of those COVID designated beds. Next slide, please. I wanted to talk a few minutes about staff. Staff is also a limited resource for us. From the beginning, safety and health of our staff has been a priority for us. We've used the analogy of when you're in an airplane, put the airplane mask on yourself before you put it on your child so that you can provide that service, right? So we want to keep our caregivers healthy. To date, of those 3,500 employees, 45 of our staff have tested positive for COVID. Currently, today, 11 of them are still being monitored and are off work. The interesting thing here is that all of those 45 employees who tested positive had a community transmission of COVID. It was not a workplace exposure. So our masking, our hand washing, our social distancing policies and practices at the hospital are working. The last bullet point here is even though we're doing well with our masking policies and our hand washing and social distancing in the house, we are experiencing staffing shortages. It is a finite resource. So 2 to 3 times higher absenteeism and call-ins from our staff right now. And that is often due to childcare challenges because childcare centers are closing. It is often due to family members who may be experiencing illness, including COVID. It includes a national shortage of these highly skilled nurses, right, in critical care and specialty services. There is some thought that the current stimulus checks for the unemployment folks that there's a reluctance to re-enter the workplace. There is a high demand for temporary or agency nurses, and those are at extraordinary costs. And again, it's a challenge for us to free up additional nurses by turning down non-COVID services. Next slide. Supplies and equipment are also challenges for us, and we're continuously monitoring. You've heard horror stories about the different things that are limited in supply. Just a few examples. Currently, our masks, we're okay, but as the prevalence of COVID increases, our burn rate increases. We are watching isolation gowns. We only have 18 days on hand. Lab tests have been a big challenge, both for us to do lab tests internally, the reagents and the kits and the swabs and the supplies to provide those lab tests are limited, and we don't get the normal distribution. Likewise, our lab partners are experiencing shortages of lab supplies. Ventilators we're okay on. We own 28 ventilators, and you can also use a machine called a BiPAP to help ventilate patients. And we're seeing less use of ventilators for COVID patients. Monitors. We needed additional monitors on our COVID unit to the tune of $1.2 million in additional monitors, 26. And the lead time, because everybody's buying them out there, was 2 to 3 months. We just got them and we're beginning to install those. Next slide. Okay, in summary, just some summary thoughts. Kootenai Health is the only full-service hospital in North Idaho with the expertise and depth in critical care and certified staff. We're uniquely qualified to care for critically ill COVID patients. We have a plan. We are ready to adjust and flex and accommodate the needs for COVID patients, but as I illustrated before, it may come at an expense of limiting other services to our community. We're at that tipping point. There are finite resources. We talked about equipment, supplies, beds, staff, right? And continued spread of the disease in our region will continue to stress our system and could limit access to those non-COVID type services. I think that's it, Nick. Yeah. So just a little quote to think about as we move forward. I thank you for your time, and I think John wanted to conclude with a few other comments. Thank you.
So once again, thank you very much for your interest in this important topic. So I just had a couple of really short closing comments. So currently, North Idaho does not have what's called a regional response plan. And so we got a hold of the current Eastern Idaho Public Health Response Plan. And I have copies of it for you. There is a health district board of directors just like you in Eastern Idaho that adopted this plan on July 14th of this year. And so we took our numbers and we plugged it into their plan, and based on Eastern Idaho's classification, our assessment is that we have moved in Kootenai County in particular from low risk to moderate risk in the last 3 weeks, and we are clearly headed towards high risk. Their plan in Eastern Idaho is that there is a series of actions associated with each of these phases. So this is a time for us to come together and to remain calm. This is nobody's fault. Nobody created this situation. But I think we all love living in this community and cherish our friends and neighbors. If there was ever a time to come together, this is it. So it is our opinion that it would be in the best interest of the residents of North Idaho that we also adopt a regional response plan through the Panhandle Health District, and we work together with you on this important initiative. And we really thank you for all of your important efforts and support you going forward. So thank you for the opportunity today.
Okay, we will take a brief moment if there are questions from board members only. And Mr. Evans, you want to come on up just in case you would know the answer to whatever questions. Any questions from board?
I have a couple of questions.
Okay, Dr. Banks?
In order for someone to enter the hospital, they have to be tested for COVID-19, is that correct?
So patients can always enter the hospital through the emergency department at any time. And
To be admitted to the hospital?
Yes.
And that's to protect the hospital staff, is that true?
Right.
So,
And family members and guests.
So if someone is at the hospital for some other reason and they test positive for COVID-19, are they listed as a COVID-19 patient?
Yes. And we would want them to be isolated properly so that we can control the spread.
And as for the staffing shortage at the hospital, didn't you lay off 211 employees?
No, we did not.
No, so let's just explain that. So, facts are important. So remember in the presentation when we discontinued doing elective surgical procedures in the protection of other patients? Our volumes dropped significantly there was little work for some of our employees to do. We did not furlough any patient care employees. We furloughed non-patient care employees, for example, in the business office, other administrative departments. They went on furlough, and they also then became eligible for state of Idaho unemployment. And we kept their benefits in place and have brought all of them back. This has been done in hospitals all across the United States due to this unique situation.
All right, other quick questions? Yes, Glenn?
Yes. I notice you're wearing surgical masks, and you think that those protect you from the virus.
So there are,
You think they protect me if you had the virus?
there are any number of different masks. Part of the uniqueness of this particular presentation, which is really important today, is some of the N95 masks and others make it very difficult to speak.
They do.
It's a challenge. So we're trying to do the best we can to represent our goals and also share the message.
Okay. Do you have a scientific study that shows that those masks, and we're talking about coming up with a plan to reduce the spread of the COVID virus, okay? You're recommending that we mandate the use of those masks, correct?
So, let me back up to the presentation. At the beginning, we did not come here today to recommend to you universal masking. I said that in my presentation. We came to you today at your request to present an update on hospital capacity. The decision about masking cannot be made by Kootenai Health. We don't have that authority. There are only 4 ways for that decision to be made in the state of Idaho. The governor, the State Department of Health and Welfare, this board of directors, and local mayors. Kootenai Health does not have that authority, and nor is that the reason we came here today.
Understood. That's not my question. Do all of your employees, staff, wear that mask constantly?
Yes.
Okay.
100%.
Do you feel that that has helped to limit the spread among your employees?
Yeah, in the numbers that I showed, 45 of our 3,500 employees since the beginning of this pandemic have tested positive, and not one has been due to a hospital workplace exposure. They've all been community transmissions.
That's
working.
what I was asking.
It's
Thank you.
working.
Okay, that is your opinion that it's working. That is anecdotal. It is not scientific evidence. Thank you.
Any other questions from board members? That includes...
Yes, Chairman?
Yes, Jay?
Yes, sir. Yes, I do have a couple questions, and I want to first off thank John Ness and Jeremy Evans for coming today and presenting the information. I think it's helpful. John, in particular, not that long ago on July 8th, the Board of Health passed or published a position statement strongly recommending and strongly endorsing 3 things. That's community-wide use of masking, physical distancing, and frequent hand washing. Since the board took that position, what do you see the impact in positive cases, COVID admissions? Do you know if that position has made an impact at all?
So Jay, we applaud that decision, but I think in my comments previously I mentioned due to our circumstance, in particular in Kootenai County, what has happened in spite of best efforts is that the number of hospitalized COVID-19 patients has gone from 3 in early July to 26 this morning. and the number of positive COVID-19 tests has gone from about 400 to about 1,100. So in spite of best efforts, and we applaud the decision that you made, it seems to Kootenai Health that we need to do more.
Mr. Chairman, I have another question.
Okay, Jay, does that conclude your question?
No, it didn't, sir. If I can continue.
Yes,
and
go ahead, Jay.
I can go ahead. Okay. John, just another question. You know, I hear reports on the news that hospitals of your size and maybe even larger are, you know, easily overwhelmed with COVID-19 admissions in a rapid time frame. What are your, I mean, you mentioned, you know, where you're at, the moderate risk moving to high. What are your concerns and projections for Kootenai Health becoming overwhelmed if the increased rate of positive cases continues? And do you know about when this might be?
Yeah. We have been doing projections. It's difficult because it's all based on one's assumption about positive test results. And the rate limiter for Kootenai Health is our ICU capacity. That is really key to this. And as Jeremy mentioned in his presentation, we have 26 ICU beds, and all of the staff there are trained in critical care. So we have developed a contingency plan, and Jeremy, you may want to speak about that. What happens if the ICU is full? Because we need to be prepared for that possibility.
Right. So we have expanded the number of designated beds that can accommodate COVID patients in the hospital. As I mentioned before, we have 26 ICU beds. We have added 32 beds for COVID designated patients. 6 of those 32 are for critical care. So we've added 6 to the 26, or up to 32 critical care beds as well. The thresholds, as I mentioned before, is when we hit about that 32 number, then we're going to be looking at reducing services elsewhere so that we can reallocate the staff, the supplies, the resources to care for the COVID patients. It's a tricky, tricky balance. And so our plan is to have a very fluid plan that we can dial up and dial down depending upon the need. Jay, your question about when do we reach that point? We're nearing it, right? And the only thing we can say is as we see the number of positive cases in the community increase, there is about a week or two lag before we start to see that hit on the inpatient side. So we're studying those numbers. So there's a lot of different models out there, but right now the trajectory is up.
Can you mention the Spokane hospitals?
Yeah, and again, Spokane hospitals are seeing the same thing. They're seeing high volumes of COVID patients. Their ICU beds are becoming full with ICU or with COVID patients. At this point in time, they're not looking for us to help augment their capacity, but they are experiencing the same thing.
Does that take care of it, Jay?
I think so. Thank you, Chairman. Thank you, John. Thank you, Jeremy.
All right, we'll go to Glenn in a moment, but first let's go up to Boundary County. Walt, we haven't forgotten about you. Do you have any questions for either of these two gentlemen?
Mr. Chairman, Walt dropped off, and I'm going to need a moment to be able to get him back on.
All right, thank you. Glenn, the floor is yours.
Thank you, Mr. Chairman. Gentlemen, I appreciate you coming and giving your presentation and responding to our questions. My question now is your COVID patients, treatment. How long, on average, are they in your care for treatment?
Dick, you might want to speak to that.
It depends on their clinical course. We could admit someone who has moderate symptoms and treat them for their presentation of respiratory, usually abnormalities, and they would begin to recover quickly. In 2 days, our test results turnaround are less than a day for inpatient. So that patient could be discharged on day 2. On the other hand, we have ICU patients. I don't know the length the longest length of stay so far for COVID? Do you know off the top of your head, Jeremy?
I don't know off the top of my head, but obviously ICU patients are staying longer,
Right.
7, 10 days.
Yes, so it can go on and on. We have to comment on something, though, because we have COVID patients recovering who need to have admission to advanced care or back to long-term care. And we have a big crisis building because of what John was saying, is that our long-term care facilities are saying time out on COVID patients. So certainly that'll affect you in Sandpoint. It's going to affect everybody.
Obviously, they don't want to infect their other
Correct.
people.
Yep.
Okay.
Right.
Follow-up question to that. Obviously, our knowledge on how to treat COVID is evolving. Have you seen improvements in your treatment programs and ability to treat these cases?
You know, we're, and Dr. McClanders, you can speak to this too, because you're in the business of treating these patients. Maybe the most important forgotten word in all of this is not coronavirus, but novel. It's new.
It is.
It's new to physicians, scientists, clinicians, pharmacists. And so as a result of that, there is no absolute proven therapeutic treatment at this time. But what has happened is that critical care physicians and others are learning how to manage these patients through the use of different medicines, steroids, etc. And it seems like in the country we're starting to get a handle on how to better manage them. But there is no proven absolute therapeutic treatment for this at this time. So it's a challenge.
That's understood, but it is evolving rapidly.
Yes.
A vaccine is being developed. It hasn't arrived yet, but it is in tests, which is unheard of to develop a vaccine that quickly. So we are working on it as a country. Okay, the state of California is in lockdown. How are their numbers? They're going up, probably about the same rate that we are witnessing numbers here. Other states that are in lockdown, not just stage 4, stage 3, but stage 2 and 1, their numbers are increasing as well. Probably because we've had the holidays and the 4th of July, we've had large congregations, we've had protests, we've had youth who are disregarding wash your hands, wear a mask, social distancing. A lot of people have been very cavalier about this, so that's understandable. Do you have a public relations program? Are you getting time on public service announcements to remind people, please, social distance, please wear a mask if you're going to a large group. If you have other comorbidity, diseases, heart, lung, diabetes, etc., avoid social gatherings. Are you able to do that with your public relations?
So since we first started Incident Command, we have always done our Incident Command management model with Panhandle Health District and Kootenai County Emergency Management. Laura, you may have the number, but I think we have probably done 40 or 50 articles, announcements, we have newsletters, and, you know, but honestly, I would say maybe the true answer is not enough. I mean, how can you do too much? We have to do more, but I think we've spent a lot of time on it, and it's complex. It's emotional, it's confusing, it's complex. I wish we could do better, and I think we've done fairly well, but we need to do more.
Okay.
So, good question.
Thank you, Mr. Chairman. That concludes my questions.
All right, any other questions? We've taken quite a bit of time on this from the board. All right, thank you, gentlemen, for your presentations today. We'll see what tomorrow brings.
Thank you for everything you do. Appreciate it.
Mr. Chairman?
Oh, yes.
It's going to take me a couple of minutes to get Mr. Kirby back on. May we take a recess for just a couple of minutes?
All right, we're trying to get Mr. Kirby back on, our board member from Boundary County. Take a quick recess. Your patience with the question mark? All right. All right, we are back to order.
This one.
Okay.
Put it on here. Let me put them over here, and that way.
All right, we are at item 6 on our agenda. This is the COVID-19 update and potential Board of Health response in Kootenai County. Is there anyone who wishes to speak to this issue? I'm open for a motion, a comment. We're back in session. What is your pleasure?
Chairman Thompson?
Yes, Glenn?
I think that we have all been very interested in the comments from the public, and they have reviewed issues that I have found very important as far as the COVID-19, its threat to us as a community. I have observed, as have others, the rise in the case numbers. But at the same time, I have not seen a commensurate rise in the death rate. We've had several more deaths occur. I have tried to get information regarding those deaths because that is important for us to know and to understand. We, I think all of us, have seen the studies, the science, the facts, the data that demonstrate that in the higher age groups from 65 to 70, 75, 80, 85, 90, your probability of requiring hospitalization increases if you get COVID. We have observed also that comorbidity health issues such as too much weight, diabetes, heart disease, lung disease are all contributing factors. And I have been interested to learn that the numbers, the individuals that have been identified with the COVID-19 virus, those numbers are duplicated in several instances, or I'm finding it difficult to find an accurate count, which causes me to lose trust in the information that we are receiving. Now, our hospital rates, the bed occupancy, that had been increasing, and that's to me a good indicator that things are on the rise. But at the same time, like I say, there has not been a commensurate increase in the death rate. So based on that information and my personal use of cloth face masks, of the N95 face mask, which I found difficult to be able to breathe through this, and as has been commented on, if you have a port in this thing, your breath is going out. Yeah, you're being protected from incoming to a certain extent, but these things do not screen out all the virus. A virus that's 0.001 microns and a mask that is capable of screening out 0.003 microns is like trying to stop a mosquito with a chain link fence. It doesn't work. It should be common sense. We have been told to maintain our social distancing. I have seen this in practice at the places that I shop and at the various places that I go. I think we are all becoming more aware of the social distancing and of trying to screen our spittle to as maximum extent possible. But it is impossible to totally avoid this virus if it's there. There's something, a concept called herd immunity, where as the more number of people that are exposed to the virus, the less effective that virus is in causing mortality and death to our population. We cannot isolate ourselves for 2, 3 months, 6 months, a year, 2 years. How long is this going to go on? We know that our government and our industry, our businesses are working hard on coming up with a vaccine. Vaccines are in the test phase right now. That is a positive development. I am glad to see that. We know that there are medications and treatments that have proven successful. Our medical community is learning how to treat this virus and the victims of it better. So that's where we are. The situation is evolving. We are seeing an increase in the numbers identified with the virus, but at the same time, we are not seeing an increase in the numbers of death, and that's a positive in my view. Can we slow the spread of the virus? We have been trying to a certain extent, but I see people all over the place without the masks. I see youth and young people partying and doing things without taking these precautionary measures. In my opinion, I do not see that mandating the use of a mask, whether it be the N95 or a cloth mask, is the answer to this. I think that educating the people and encouraging them to use these things, washing their hands, maintaining the social distancing, wearing a mask if they feel that they should, but I do not see mandating it as the answer. That's my opinion.
All right, any other board member wishing to comment?
Yes, Mr.
Dr. Banks?
Chairman. When this whole thing started, I was willing to believe that there was a dangerous virus on the loose. But as the numbers began to accumulate, I realized something was wrong with the official story. As more data came in, it became clear that deaths with COVID were being called deaths from COVID. Then I began to look for holes in the story instead of believing the story because of the logical inconsistencies in the story, and I found a lot of information which I believe is relevant to today's discussion. Masks do not work. The latest CDC publication in Emerging and Infectious Disease, published May 2020, that was last, a month and a half ago now, does an analysis of 16 randomized controlled trials showing no benefit to the rate of influenza infection from wearing masks. They obviously were studying influenza because These are a number of random clinical trials that were done in the past. The authors were surprised because they were all medical personnel, they were all MDs. They were surprised that the mask didn't work, but they went with the science. Masks do work in a surgical suite, in a sterile surgical setting, but they're not intended or designed to prevent the spread of viruses. They reviewed studies using surgical masks, N95 masks, and cloth masks. None were effective at reducing the rate of influenza infection. Influenza virus is 5 times larger than coronavirus, and we can therefore expect that these same masks would not stop a much smaller virus. Masks are not only ineffective at preventing viral infection, they're also harmful. Prolonged wearing of masks is harmful, leading to higher infection rates and impaired cognitive function due to oxygen deprivation and carbon dioxide buildup. What does the science say in large-scale trials? Because we've conducted a large-scale trial right here in the United States over the past many months. In the USA, 11 states had no restrictions. 39 states had mask mandates and/or lockdowns. That's a large sample with 330 million participants. The data show that the non-restricted states had slightly lower infection rates and death rates from COVID than the mandated mask lockdown states. This is a large-scale confirmation of the previous scientific findings. Masks do not prevent infection. Lockdowns do not prevent infections. What did the PCR test companies say? I looked at the instructions from several companies that provide PCR tests. The package insert instructions specifically say that a positive test result should not be considered a positive case without corroborating symptoms. Here's what the World Health Organization coronavirus disease, COVID-19 technical guidance, laboratory testing for 2019 novel coronavirus in humans says. Several assays that detect the 2019 novel coronavirus have been and are currently under development, both in-house and commercially. Some assays may detect only the novel virus, and some may also detect other strains of coronaviruses that are genetically similar. Translation: some PCR tests register positive for types of coronavirus that have nothing to do with COVID, including plain old coronas that cause nothing more than a cold. From the manufacturer of PCR test kit elements, Creative Diagnostics, SARS-CoV-2 Coronavirus Multiplex RT-Q PCR kit, non-specific interference of influenza A virus, influenza B virus, Yamagata strain, respiratory syncytial virus, respiratory adenovirus type 3 and type 7, parainfluenza virus type 2, mycoplasma pneumoniae, and chlamydia pneumoniae, etc. Translation: although this company states that the test can detect COVID, it also states the test can read falsely positive if the patient has one of a number of other respiratory viruses in his body. This may explain the huge number of false positives. A positive COVID test is not a COVID case. There are many false positives. Connecticut recently reported 90 of 144 false positives. That's a 62% false positive test rate. Iceland, several months ago, reported 50% false positives in a nationwide test of the PCR test. Tanzania found the test identified COVID-19 in a goat, a pheasant, and a papaya. Based on these results, they returned the test to the WHO, saying they were ineffective. A recent Chinese paper reports 80% false positives in COVID testing. Florida recently reported 95% of the population positive for COVID, likely due to false positive testing.
I guess I'm just going to have to give it up. It ain't going to work.
Idaho Reports Walt is unable to hear. Idaho reports, on average, about a 15% positive test rate for COVID-19, but 99% of these have no symptoms. A positive test rate is being called a case when it is not.
Verizon thing up here is terrible. It's worse than terrible. So that's how come I've got this 267-4034 landline.
Okay.
I hope so, and I hope that Verizon's damn well listening. But at any rate.
Okay, Walt is back. Idaho health authorities are calling these positive test results COVID-19 cases, even though, according to the test manufacturers, these should not be counted as positive cases without corroborating symptoms. Why do we have an exponentially increasing number of cases? Because they're doing more tests. And the more tests you do, the more positives you're going to find, because they're up to 80% false positive, or if you're in Florida, 95% false positives. Okay? Summary. Masks do not work to prevent viral spread. It's been clearly shown in CDC studies and in paper after paper after paper, which I have forwarded to the board. Lockdowns do not work to prevent viral disease. That was proven in a 330 million person study done over the last several months. This is not surprising, since quarantine means to isolate the sick, not the healthy. The PCR test gives many false positives and is not a reliable indicator by itself. The inventor of the PCR test, Kerry Mullis, who I met many years ago, specifically cautioned against using the test for diagnostic disease. Why was that? Because it was designed to manufacture DNA. It wasn't designed as a diagnostic test. So, that is my say.
Mr. Chairman, can you hear me?
Can you hear Walt?
Are you there?
Yes, Walt.
Yeah. Excuse me, but the whole thing is so lousy up here. I just got to say a couple of things, and could I make a motion?
Yes, anyone on the board is welcome to make a motion.
I would like to make a motion at this point that we have discussed this thing up and down, and we've heard from at least 100 different people up and down, and I think that it's time for the board, those of us who are here and listening and trying to keep this thing together or take it apart or do whatever, I think it's time for I'm making a motion for an up or down vote now.
On what motion?
We need, what is your motion? We need the wording of your motion.
The wording of my motion is that I feel that my motion is I move that we have a up or down, yes or no vote right now. You know, put it up for discussion and get a second on it and put it up for discussion and let's vote.
But I still don't understand the total verbiage. We need to know what yes means and what no means.
Okay. Yes means we will mandate the use of masks. No means that we will not mandate the use of masks, but recommend it heavily.
All right, Walt, I'm going to, there's not been a second to this yet. I'm going to turn the microphone over to our legal counsel, Mr. Lyon, at this time for his comment.
I love that. We need his comment.
Okay, Mr. Chairman, and I assume Walt can hear me on this. Really close, okay, let's do this. Okay, Mr. Chairman, there is a draft order that the board members have all seen, and there was a draft of a motion that is prepared, and I can read that if we have a board member here who is ready to make such a motion. to approve a draft order, and then if the motion is made, then I would like to explain what the draft order is so that the public understands what is entailed in a motion to approve an order mandating masks. So the way that would normally work is somebody makes that motion, and then there's a second, if there is a second, and then the board may have some more discussions if they want to amend the draft order or leave it as it is, and then we would have a vote, and if the motion passes, it passes. If it fails, it fails. So at this point, I think what we need to do is we need to have, to get this issue out, we need to have a motion I think one way to do it is to have a motion to approve a draft order, if that's what we want to do.
Okay, Walt, what he's saying is the draft would cover what you are trying to, Walt, the motion that our attorney has drafted would cover what you are asking, and then we'll see if this motion he has drafted gets a second, and if so, then we can discuss it and vote.
Okay, gotcha. If he said yes, no, like I'm talking about there, I think he does. I'm so moved, Mr. Chairman.
Well, all right, but we need to have it read, and I'm going to ask Dr. McLandris, do you have a copy of that motion? Do you wish to make a motion at this time?
I'm not clear on what did Walt make a motion, because I could not hear him clearly. Is he moving to?
Walt was just saying, I want to move yes or no, but he did not make it clear the verbiage of his motion, and that's where we can't take that motion unless we know the details of that actual motion.
Certainly. So I hear Walt not clarifying that motion. Is that what you're saying, or is he saying?
That is correct.
That's correct. So with more background that we can discuss, then, Mr. Chairman, I would move that the District 1 Board of Health approve and authorize the board chair to execute the order proposed in draft form, effective immediately.
All right, would you repeat that?
Sure. I move that the District 1 Board of Health approve and authorize the board chair to execute the order proposed in draft form, effective immediately, to become effective immediately.
And,
all right.
Mr. Chairman, if I could clarify what the draft order is so that I think all the board members know what that is, but if I could clarify it for the public. As I mentioned last week at the meeting, there is a draft order that is similar is a template of an order that is similar to that passed by the Central Idaho Health District. The order this draft order is also similar to the one drafted or approved by the Eastern Idaho Health District. The order does, in its operative language, the draft says that it would be an order that every person in Kootenai County is required to wear a face covering that completely covers the person's nose and mouth when the person is in a public place, and physical distancing of 6 feet from others cannot be maintained. There are exceptions, and the exceptions, I will go through them very quickly. Facial coverings are not required under the following circumstances. A, when individuals are immediate family or household occupants. B, children under the age of 2. C, persons with medical conditions, health conditions that prevent them from wearing face coverings. D, persons who are communicating with a person who is deaf or hard of hearing, where the ability to see the mouth is essential for communication. E, persons including on-duty law enforcement for whom wearing a face mask would create a risk, a person related to their work. F, persons who are obtaining a service involving the nose, face, or head, which temporary removal of the face covering is necessary to perform the service. G, persons who are eating or drinking at a restaurant or other establishment that offers food or beverage service, so long as they are seated at a table and able to maintain a distance of 6 feet from persons who are not members of the same household party. This exemption does not apply to entry, exit, or other movement through the facility. H, persons who are incarcerated in a jail or related facility. I, when necessary to confirm a person's identity. J, when local, state, or federal law prohibits wearing a face mask covering or requires removal of a face covering. So those exceptions are essentially the same as the Eastern and Central Healthcare District orders. This particular draft that we're talking about, when we say draft, that's what we're talking about for this motion. This is actually more limited than those in that it relates only to masking and not other restrictions.
Thank you. So, this is a draft, and if this is what Walt wants to call his motion, he may so declare, and then I would call for a second, and then it can be discussed. So, going back to you, Mr. Kirby.
Order.
Oh, I'm sorry.
I wasn't clear that he made a motion, so I made the motion.
Just one moment, Walt. One moment.
If he would like to make the motion, fine, but it was clear to me that he didn't make that motion, so I made the motion. So he could, I'm happy to relate to him to make the motion or for him to choose to second if he wishes.
All right.
Mr. Chairman, just for the record of the proceeding right now, the only motion that is on the table is Dr. McLandris's motion, and we just wanted to make sure that Mr. Kirby heard and understand that.
All right. Did you catch that, Mr. Kirby? The only motion is from Dr. McLandris, and it's this draft. And if you would wish to second the motion from Mr. McLandris, you may do so.
I would second it. There you go. It's seconded.
All right. It has been moved and seconded that we adopt this order of the Board of Health, Panhandle Health District, State of Idaho. It is now open for discussion.
If I could ask, Mr. Chairman, I know that Jay is online, and as the other representative from Kootenai County, I'd be interested in her comments and questions.
All right. Jay, Dr. McLandris is asking for comment from you if you have any.
I appreciate that, Chairman and Dr. McLandris. I just one comment to start. I want to thank all the individuals who've reached out to me and provided input and comments. I have not been able to respond to everyone. I truly wish I could. It's been a high volume, especially in the last couple days. I also want to thank all the medical doctors I've heard from in the last couple days. I appreciate your comments. I've heard from the director of Camp Luther Haven, I believe it was today, supporting masks for that camp and the children that use that camp. I heard from a school board trustee member this morning that their statement was, to me, this is a pivotal decision, that board trustee wants the kids back in school. Their concern was about abused and neglected children specifically, and that school being a safety net for that particular issue. So thank you everyone for all your comments. They've weighed heavily. I reviewed, I'm going to say the vast majority, which has taken some time, but I feel like I need to do that. And one common question from the public is about our legal authority to do what we're talking about today, and that is mandate a mask, a face mask wearing. And so I think it would be good to address that, Mr. Lyons. Here's my understanding, and then I'd like you to weigh in. Idaho Code 39414, subsection 2, health districts have the general abilities to do all things required for the preservation and protection of the public health and preventative health. So, Mr. Lyons, my question to you and your legal expertise, from my perspective, that's a sweeping grant of power to do all things required. Would you just weigh in for myself and the board with your legal input?
Thank you, Board Member Nelson. Yes, I agree that it is a sweeping grant of power. The health districts throughout the state have, by statute, been granted the same authority to act with respect to health emergencies that the Department of Health and Welfare has. The original grant of statutory authority that's given by the legislature to the Department of Health and Welfare is to to issue orders or have the power to impose and enforce orders of isolation, quarantine, protect the public from the spread of infection. That is all in Idaho Code 561003. And there are administrative code rules that also interpret that, I think, in my opinion, consistently. And that would include the ability to restrict activities of persons to reduce the risk of transmission. That is Idaho IDAPA 160211. So it is a broad grant of authority, admittedly. So what happens with the health district? In the health district statutes, the legislature has given the health districts essentially the same powers to act in the event of a healthcare emergency. So yes, the health districts in the state of Idaho do have broad powers. Other health districts have exercised some of those powers. Some have not exercised those powers. I believe that there is authority to do this, and it is up to the board to decide whether to exercise these powers or to not exercise these powers. That's the issue before the board today.
Thank you.
I think Jay may have another question.
All right, Dr. McLandris. Jay, do you have any other questions?
I have, yes, some more information if you don't mind.
Okay.
Thank you, sir. Yesterday, Board of Health received a letter from Dr. Stephen Cook. He's the superintendent of schools, Coeur d'Alene School District. And Nick, I forwarded you this letter. Can you put it up on screen, please?
It's going up on screen right now.
So my statement about this letter is this: along with all the public comment, healthcare workers, doctors, this letter was compelling to me. And again, since we just received it yesterday, I'm pleased to at least see that if there's low community spread, that they plan to open schools in the fall and with attendance in person 5 days a week. However, there's significant and substantial community spread. It looks like their plan is to go online. And I, again, wasn't aware of this till yesterday. The second paragraph, with the start of the new school year fast approaching, we are watching with alarm the recent spike in positive COVID-19 cases in our region and the communities we serve in the Coeur d'Alene School District. It remains our goal to bring our students back into classrooms this fall, and we intend to do all we can to prepare for that. We cannot, however, do this alone. We are relying on a strong show of support from the public and our partners in governance to bring down the rate of transmission so that we can get our students and staff back in the buildings and keep them there. The last paragraph, he states, Dr. Cook, I would urge you to consider all options at your disposal to help mitigate the spread of the virus, including the option of a temporary mask mandate. I implore you to help our community flatten this curve and avoid a slide in this critical stage of the pandemic. And I did want the public just to be aware of that since we just received that yesterday. My other comments, you know, some of the speakers and some board members, I appreciate Mr. Ness and Mr. Evans, I think it is, speaking about our hospital and available beds. That is concerning to me. I didn't realize how full they are. And I think the death rate, not just in Kootenai County, but nationally, locally, regionally, is significant. And I've seen reports comparing it to influenza. And Nick, I don't know, I sent you a few charts. Do you have those handy, and can you put those up? Thank you. So these are my own charts. I'm going to go a little Ross Perot. I made my own charts. This is compiled data that I got from the CDC. But here you can see a comparison to influenza, and this was just this last season, October to April of this year. And influenza, as you're probably well aware of, but you know, it's 6 months is typically the season. And right now with the pandemic, if you look at the cases so far, and then projected cases, an analysis, it continues to rise. Hospitalizations for the flu, those are the numbers I have there. That data was a little bit hard for me to capture, other than the quote I have there that the hospitalization rates for influenza over each of the 5 seasons, it is higher with COVID-19. And then the next page, please, Nick. And here are the deaths. I know we talk a lot about percentages and rates per 100,000. And we look at graphs and linear graphs, but I'm kind of a numbers person. And so I had to chart this out for myself. So again, we're looking at the flu season, just this last year only, 24,000 to 62,000, pretty wide range. And this is the U.S., the entire U.S. COVID-19, we know we're at 141,000 as of yesterday was this data. And then I had 2 different projections I looked at to November 1st without a mask, going up to 208,000. And then if there was a mask mandate, again, you can see there's 95% would be lower rate, 162,000. Still a lot of deaths in this country so far, and it looks like it's continued to rise. And then Nick, if you would go to the third and last graph. I did not make this one. This data came from the National Center for Health Studies. And what I thought was interesting about this, and Alan mentioned some things of, you know, did they die of COVID? What did they pass away from? Did they have other comorbidities? So I think this is a little interesting because it does show that we know pneumonia can be challenging for some folks, and including influenza. So they could, because COVID causes pneumonia, They could have a dual diagnosis. That appears to be common. And so there are some of the numbers. And this is an estimate of excess deaths. So it's not just the COVID, it's the other comorbidities that are potential with COVID. I've also read a couple of, thank you, Nick. You can take that down if you wish. I have been reading significant amounts of studies and research. That's who I am as a nurse and a healthcare provider. And I did read something that I thought was interesting because it came from outside healthcare. It's an article called Aerosol Filtration Efficiency of Common Fabrics Used in Respiratory Cloth Masks. And this study came out in April of this year and was updated on June 18th of this year. They looked at aerosol rates, mechanical filtration, electrostatic filtration. And they looked at cotton, silk, chiffon, and they found that of those fabrics, cotton, natural silk, and chiffon can provide a good protection, typically above 50% in the entire range of 10 nanometers to 6 micrometers. So their conclusion, materials such as silk and chiffon are particularly effective considering their sheerness at excluding particles in the nanoscale range, likely due to electrostatic effects that result in charge transfer with nanoscale aerosol particles. And I have read another study that COVID-19 aerosol droplets remain in the air from up, depending on the size of the droplet, from 3 hours to 8 hours. They went on to conclude a 4-layer silk was surprisingly effective as an average efficiency of greater than 85% across the 10 nanometer to 6 micrometer particle size range. And they concluded, as a result, we found that hybrid combinations of cloth, such as high threads per inch cotton along with silk, chiffon, or flannel, can provide broad filtration coverage across both of the nanoscale, less than 300 nanometers, and the micron scale, 300 nanometers to 6 micrometers range, likely due to the combined effects of electrostatic and physical filtering. And then the other report that I'd just like to mention of everything I've read and digested recently was an article in The Lancet. This came out fairly recently, June 27th of this year. This was the most comprehensive study to date, providing evidence on physical distancing, face mask, and eye protection to prevent the spread of COVID-19. What this study concluded, for the general public, face masks are associated with a protection even in non-healthcare settings with either a disposable surgical mask or reusable layered cotton mask. The Lancet study that has been mentioned concluded with a 3% infection rate for individuals wearing a mask and a 17.4% infection rate without a mask. And as our medical advisor, I'd like to ask Dr. McLanders a couple questions. He mentioned it at our last meeting. We did not have 2 board members there. And so I'm hoping he can discuss that a little bit. As far as I know, he's been a medical provider and physician for decades. And just the spectrum of from when he started his career as a doctor, you know, and all these new findings, does he find anything compelling to report to the board?
Dr. McLanders.
I can respond to the methodology of doing studies and how do we dissect the study? How do we decide if it's true or not? And so we look at studies that are authored by an individual who's an expert. And then we look at a study that's authored by 5 experts. And then we look at tens or teens or 20s of studies done by multiple experts. And so as the gentleman earlier in the public comment talked about, this Lancet article is a classic case of how do we learn more by bringing in multiple experts and looking at a huge number of studies and learning how to throw out the studies that aren't helpful to come to a reliable conclusion. So the latter statistics that Jay just mentioned regarding with a reasonable certainty an 85% reduction in transmission of the COVID virus is related to several facts. And this paper is the reason that the CDC and the WHO changed their mind in June. They flipped, as you know, from, hey, masks aren't going to work, to, hello, everybody wear a mask. So this study was published June 27th, and it's the correlation of 172 studies in 16 countries that reviewed 25,697 patients. This study confirmed with a degree of certainty that we can reasonably expect an 85% reduction in transmission. So why is that? These viruses are teeny. They're teeny. However, they are transported on droplets that are much bigger than the virus. So if we can capture the droplets and get close to capturing the aerosol, which is way smaller than a droplet, then we have a chance of reducing the communicability. So then it's about what the virologists and epidemiologists call viral load. I could walk by you, and you may have COVID, and your spread of the virus may be X millions, but it turns out to be Y millions needed for me to catch it from you. So if I'm wearing a mask that literally catches most of those droplets and a whole lot of the aerosol, my chance of getting the disease is way lower. And these are a large team of experts, multiple authors on this paper, and they tried their best to throw out those studies which are like, oh, that study doesn't look so cool. So my feeling is that we have a great opportunity, and I rely upon this particular study, as literally the WHO and the CDC has. So I just want to respond to that question. Jay, does that help your question?
Yes, it does. Thank you.
Okay.
And I do have another one for you, if I can. At our last meeting again, Dr. McClandress, and again, because two board members were not there, you talked about the long-term symptoms and effects from someone who recovers from this disease. And I think Glenn mentioned, some of the people at risk. He didn't mention cancer. He didn't mention immunocompromised, heart failure, coronary artery disease, COPD, asthma. But I've also read there's lasting, at least for what we know now, lasting damage to lungs, heart, kidneys, brain. You spoke specifically about the clotting, and that's a concern to me. My background's cardiovascular nursing. Do you mind kind of updating the board on what you've been reading currently on any of that?
Sure. Thanks. It's another study of how do we learn more over time. We invest much expertise in a series of studies to look at what we're finding in autopsies of 30-year-olds, of 20-year-olds, of 80-year-olds, looking at the tissues and try to figure out what's happening. So there is this issue, and I initially thought this is like influenza. This is going to cause failure of the mechanism of the alveoli, the little sac in your lungs that gets the oxygen into your blood vessels and the CO2 out. So we thought we could hook you up to a ventilator and push pressure and push that oxygen into your blood vessels. Sorry, that didn't work. And the ER docs and the pulmonologists in New York City are the ones that figured this out. Those patients were not responding to the typical treatment for influenza. And so then the scientists in the lab started looking at all these chemical studies we do, and we've learned that there is an inflammatory response. Our body, not everybody, but the people who get sick, our bodies call it overreact, and they create trouble in trying to kill this virus. So that creates admission to the ICU, sure. However, the scary part, and this is the big thing that we're going to know much more about in a year, but we do not know now, we know that young people have a much higher incidence of large vessel arterial thrombus, i.e. stroke, heart attack, acute kidney failure due to thrombosis of the major arterial supply to the kidneys. But even more scary are the small blood vessels, and this is where kids are coming in. We started seeing kids who have what's now called COVID toe. The toe is, anybody have Raynaud's phenomenon when your finger turns white if you get cold, right? The arterial supply blocks down, so your finger turns white and cold. Well, this kind of inflammatory reaction is causing the same thing to kids. Not in a high number, because we don't see the numbers yet, but we know it's happening. So another important fact is that we're seeing people with cognitive dysfunction who literally had very little in the way of symptoms. So the documentation now is the small blood vessels to the brain are also affected. And we're going to know a ton more, but right now we know darn well that there's way more to this than lungs and I need a ventilator or I need BiPAP. So we're in the learning curve. My advocacy is to do whatever we can do to reduce the incidence of disease caused by COVID-19. Does that help, Jay?
It does. Thank you.
Okay.
I wanted to talk a little bit also, we've talked a lot about the disease, the spread, unfortunately, the people that have succumbed to this disease. I haven't heard a lot about the economy, which is concerning to me, and I'm sure many people and businesses locally and in our region. And there was an analysis published by Goldman Sachs Research that suggested that expanding community masking by 15%, now that's not very much, could prevent the need to go back to another stay-at-home order for that community. For the United States, another stay-at-home order is estimated 5% of our gross domestic product could be impacted, or a projected cost of $1 trillion. And that is another factor with this pandemic, is the economic toll. At this time, I'd like to talk to my board members specifically. Just recently, the director of the Center of Disease Control and Prevention, he said, if we all wore face coverings for the next 4, 6 to 8 weeks, this virus transmission would stop. And I know we all want this virus to stop. We need to do this together as a board and a community. We're all tired of staying home, tired of seeing businesses struggle, tired of hearing about the death rate. We need to do whatever we can to take control and defeat this virus. This pandemic is a political issue, and wearing face masks are also a political issue. But that does not alter the fact that it is a public health crisis, the most critical public health crisis in our lifetime. If a public health board is ever going to take any action, shouldn't it be now? Our statutory mandate as board members is to do the preservation and protection of health and preventative health. It's my personal ethical standard. It's always the right time to do the right thing. It's time to do the right thing. And in the case of this pandemic, the right thing is to require face coverings. Mike, it's time to do the right thing. Marlo, it's time to do the right thing. Walt, it's time to do the right thing. We need to follow our statutory mandate, the preservation and protection and preventative health. Thank you, Chairman.
Thank you, Jay. Yes, Dr. McClandris?
I would just like to add a few comments, if I could, in the discussion. I've read more than 250 emails. I have talked to many compatriots, both here and literally where the rubber meets the road and where people are really sick, and it's very difficult for healthcare professionals. I have had acquaintances who are healthy die from this, who have worked in the emergency departments across the country, one in Seattle, one in Minneapolis, and one in New Jersey. I talked to Sarah, who's Governor Little's primary on the phone liaison extensively 2 days ago. Governor Little has given us in each community the responsibility to dissect our community, to get to know our community and know our numbers and know our capacities, and then to be able to act accordingly. And then that's his prerogative as governor. He has indicated that throughout the state. And certain parts of the state have responded, as you know. I feel that this is where the buck stops. I feel that we have dived into a lot of research, and I can say that this is about catching those droplets, those little teeny pieces of water that we breathe out, so that Glenn sitting next to me is not going to get high COVID virus. And so I think in combination with the issues that we know, we need to do physical distancing. And I can parenthetically say it will not surprise me at all that we need to dial back. It won't surprise me in our community that we need to close restaurants or bars, or at least go to 50% like many communities have. It wouldn't surprise me because of the rapid rise. So this is a first step, and I feel it'll be supporting our community. And I hope and pray that Sandpoint doesn't have the same thing. People are flooding into Sandpoint. It's a great place to be in the summer, and numbers there in Bonner may go crazy as well. I hope not. Our other counties and our districts are very less populated. They are different, like Mike and I have talked about. Hey, Shoshone County is very different than Kootenai County, and right on, I got it. So that would be my close. I firmly believe in personal rights. I do believe in the liberty part of our statements.
Let's have a quiet, please.
I believe in liberty. I also believe in justice. And what about the ethics of me protecting my neighbor? That's what we're talking about here. So those are my thoughts. Thanks.
All right. Mr. Lyon?
It occurs to me that I failed to mention in discussing the draft order that it is limited to Kootenai County and not the entire health.
All right, we're still open for comment. Any other board member wishing to comment?
Yes, Mr. Chairman. It must be the COVID, it's got my throat here. The large numbers of deaths which are reported, in my opinion, are deaths with coronavirus. That is to say, someone was admitted to the hospital with a serious condition, they were tested and found to be positive, and their disease took whatever course it took. Because they tested positive for coronavirus, they were then listed as a coronavirus death. There are many examples around the country. The most recent I can think of is a motorcycle death in Florida, which was listed
Closer to the mic.
closer to the mic. The death was listed as a coronavirus death, even though it was really, he didn't really die from coronavirus. He died from a motorcycle injury, but he did die with coronavirus, or at least he died with a positive coronavirus test, but with no coronavirus symptoms. And that's important. I read through 4 different package inserts, instructions from PCR test providers. Each of them gave the following caution in their first few paragraphs, which were, a positive test is not the same as a positive case. A case can only be confirmed, but with corroborative evidence, such as symptoms. So, we have cases increasing. They're called cases in North Idaho. They're actually positive tests. We know that the test tests positive for virtually any respiratory virus. And so, are we really finding coronavirus, or are we finding adenovirus? Are we finding influenza virus? We really don't know. And the test does not distinguish that. So it's an indicator, but it's not positivity. Further, without corroborative symptoms, all you have is a test. It used to be in the old days, and Dr. McLenders can probably comment on this, in the old days, patients came to their doctor and they had symptoms. Then the doctor, doing what doctors had done for a long time, would try to determine what was the cause of the symptoms. This has now been inverted completely. We have a test that is 80% false positives, according to any number of sources, and test positive in goats, pheasants, and papayas, yet we're relying on this to lock down businesses, put people out of work, mandate an unhealthy wearing of cloth masks, which have been proven to be ineffective, and for what reason? It doesn't seem to be medical to me. And for that reason, I am opposed to such an order. I think it's overly restrictive. It goes beyond our mandate as a health district, which is to, one of our powers is to quarantine. And quarantine means to isolate the sick, not to isolate the healthy. And I just cannot support such an order. Thank you.
If I could respond, I could say that categorically in our community, the vast majority of people being tested have symptoms. So that's, to be clear on that. The referrals to our 2207 are symptoms.
We'll have a quiet.
Go ahead.
All right, any other comments?
Mr. Chairman,
Yes.
can I have a 2-minute closing?
Go ahead, Walt, we'll try to get you on here.
Well, I think that the motion that I made was, and still is a good one, okay? And nobody understands it but me. And my thoughts is that this whole conversation that we've been having here for the last, I don't know, hour or so, 40 minutes anyway, that's all fine. I mean, everybody's right. Dr. McLenders is absolutely right. Jay is absolutely right. She's read it and studied it and knows about it. Dr. Banks is right. He's studied it and knows about it and so forth. And everybody's got a slightly different opinion. Every county has got a slightly different opinion. And so it's my duty as a county commissioner to carry the things, the politics out of it, and forget it, because that's not what it's all about. What it's about is there's a thing going on here about whether we should or should not require or mandate that everybody wear a mask at certain times and certain not times and so on. And I don't, it isn't going to work, because we've been sitting here all day since noon today. We've been sitting here listening to all kinds of people hollering and about absolutely not going to wear a mask. I hate them. They're no good. They don't work. This, that, and the other thing. And then the other half of the day has been spent listening to the learned people who are quoting all kinds of good data and so forth, and is saying it, and wonderfully so, are saying that a mask is important and should be worn all day, every day, or whatever, whatever the thing is. But the deal is, the thing that's in front of the board is, should one of us or two of us or whatever set it up for all of the counties, and that's not the way it ought to be. Each of us, as a county commissioner, can only speak for our county. I can't speak for Kootenai County. They got a problem. And Boundary County doesn't really have, at this point in time, doesn't have that much of a problem, mainly because we don't have that many people. And we don't have that much travel and so on. And so, at any rate, what I'm trying to say is that if we mandate it or not mandate wearing mask, is probably not going to make one whit of difference in how it all turns out in the long run, because people are people. We got a whole half a day's full of people here who are not going to go home and start wearing masks no matter what. We got a bunch of people that are listening out here, or part of the deal, or going to whip out a mask and get it on and keep it on. And that division of people that we're dealing with is not going to change. There's people that have their opinions on both sides of this thing, and they are not coming off of them. And so there's no use of us going to a lot of trouble to mandate something that we know that law enforcement will not enforce. We've been told this by several law enforcement people. And then on top of that, there's a whole bunch of people who wouldn't, no matter whether there was a policeman there or not. So I think that my vote was for each county commissioner to do what he thinks is right for his place of business, or where he lives, or what his county is, or however whatever that is how it works out. And anyway, I just can't I can't support having a mandate for something that's useless, because people are not going to pay attention to it, and there's no policeman out there. There's no way of making it work. People will change their minds. They will wake up and go one way or another after today, after an hour from now. Who knows? But anyway, I still think that the simple motion that was made was, should we, as a board of Panhandle Health, should we collectively mandate wearing of masks under certain circumstances, as we've been told by the attorney that we should have in the deal, and so forth. There's all kinds of little nuances in there, but either should we say yes, everybody's got to wear a mask, or no, you don't have to, but please do. And that's pretty plain language, and at least it's fairly plain to me, and I think that's what we are voting on, not all this other stuff. There's too much stuff. We can talk about this stuff forever, but that won't either put on or take off masks off of people. Anyway, any more of this gets more confusing. So anyway, it's an up or down vote, as I'm saying. Up being, yeah, you're going to wear masks. Down, no, you're not. Or vice versa, if that's the way you'd rather have it worded. I don't care. But that's a decision that we're going to make, and I don't think that. I think that there's enough board members Unfortunately, they're not all here, I don't think, but anyway, there's enough board members and so forth to have a vote that says yes or no on whether you will or will not be asked to put on a mask in the morning.
All right, thank you, Walt. And yes, when it comes time and the question is called for, we will vote yea or nay regarding this document that has been prepared for us. And would that it could be that simple. But keep in mind, Walt, this is for Kootenai County only, and still as a health board, we have to deal with it, even though it's one county, even if the same it would be if it were just an issue for Boundary County. It would have to be voted on by the entire health board unless the county commissioners chose to just take care of it themselves. But in this case, we are a board representing all 5 of the northern counties. Therefore, when it comes time to vote, we will vote up or down on the total of this resolution that we have before us. And if you want to call for the question, that's your privilege.
I'll call for the question.
All right, fellow board members, are you ready to vote? And if we vote, we are voting on this document you have before you, adopting it, saying we approve this or we disapprove this. And if we disapprove this, basically what we're going back to is our position statement of July the 8th.
Very good.
Yes.
Mr. Chairman, just as a clarification, what is before the board now for vote, the question, is Dr. McLandris's motion that the Board of Health approve and authorize the board chair to execute the draft order that relates only to Kootenai County, effective immediately. That's the motion before the Board of Health right now.
And is the question, I would call for the question if Walt hasn't. I don't know, I couldn't tell.
All right.
Unless one of our board members have something important to add.
Glenn?
Mr. Chairman, for clarification, this proposes that a violation or noncompliance is a misdemeanor offense, which would result in a fine up to $1,000
Yes.
or 1 year in jail.
Correct.
Correct. Okay.
As all the orders are in the state of Idaho and other states.
I'm
Yes.
sorry, Doctor, I didn't hear that. Go again.
Sorry, I couldn't hear your question.
Okay, what was your statement? I didn't quite hear your statement.
Glenn was asking a question, and I was responding, probably as Mr. Lyons could have easily too, that is part of the typical mandate that is part of this declaration of order. Yes.
Mr. Chairman?
Yes.
For clarification, if you can get law enforcement to enforce it, and if you can get prosecutor to prosecute it. Just wanted to clarify that.
Mr. Chairman, might I make a comment?
Go ahead, Laura.
Thank you, Mr. Chairman, Board. And I certainly do appreciate all the public comment we have received over the course of the past couple of weeks, most especially the past few days. John Ness and Jeremy were kind enough to come in to address hospital capacity, because that really truly is what this is all about. And I think their statistics played out just as the national statistics as far as the 80-20 rule, where 80% of the folks, as we've talked about, are going to have mild to no illness, symptoms that is. 20% of the folks are going to be pretty sick. And we've experienced that in our conversations with some of these folks that have are experiencing COVID. And of that 20%, 5% are really going to need the hospital. And our hospital, I tell you what, they are doing everything in their bandwidth, in their power, to make it so there's care for that 5% that need it. And that 1 to 2% out of that 5% that are going to need that ICU bed, that critical care bed. So, your fingers should be on the pulse of your community, of your regional hospital, because when you or your loved one or any citizen here in North Idaho needs that critical care bed, I want it to be there for them. So this is the reason for this conversation. And I know there's a lot of differing opinions, and I know this is a very difficult decision for the board, but the trajectory that we're seeing is similar to what's happened in other areas of population similar to ours, where it just keeps going up and up. And there's a and there's a few things we can do, and we know what they are. There are social distancing, barriers, and hand washing. That's what we can do to preserve or try to prevent the disease from continuing on this trajectory that we're seeing. So with that, I know the board has a very difficult decision in front of them. We're doing our best to promote healthy behaviors. And I know that the city and some of the community partners that we have here are looking at another PSA, another campaign to promote and educate. But we really just need to watch what's happening with our hospital capacity. And I'll do everything in my power to make sure you're all aware via social media, via the newspaper, via all the avenues that we have of what's going on with these 5% of the 20% that are pretty sick, and the 1 to 2% of that 5%. How are they doing? Are they being cared for, Mr. Chairman?
We will have a roll call vote at this time. And beginning with Walt, a yes vote or a no vote. A yes means the adoption of this document. A no vote means that the motion goes down to defeat. Walt, do you have a vote?
Yes.
Walt Kirby votes yes. Jay Nelson?
Yes.
Dr. McLandris?
Yes.
Dr. Banks?
No.
Mike Fitzgerald?
Yes.
I understand, yes. Glenn Bailey?
No.
We have, without my vote, we have 1, 2, 3, 4 yes votes and 2 no votes, and the resolution passes.
We're not wearing a mandate. I have kids that I care about. You may not, but I do. We will not wear. I'm not doing it. Sorry. Everybody got health issues. Not doing it. You guys didn't answer my question.
All right, we will. Now, if you think I'm able to hear all of you at once, well, you're kidding yourself.
It's all bullshit. It is. If you think for 1 second that I don't know my kids,
We will call a resource, call for a recess.
It's happening.
Meeting back to order. And the, this is almost ironic. The next item on our agenda is our fiscal report, and then the next item on after that is the election of our officers.
Thanks for sticking with me. You're on the speaker. Well, that's all right. I just thank you for working. Staying on this. That was a terrible job.
Yeah. All right. Now we want to try to get a hold of Christine. Is she ready? Okay, we're back to order, and Christine, are you hearing us?
I am hearing you. Can you hear me?
Yes, yes, yes. And you have the floor for your report.
Well, I have to say that's a hard act to follow. Mine will be quite passive, my presentation. Nick will need to unblock me so I can bring up my worksheets. There we go. Thank you. So the first thing that I'd like to address with the board is in your packets, you probably noticed that your monthly reports were noted as draft. And on the cash balances in the cash history for the board committed funds and program restricted funds, they're designated as estimated. The reason for that is because it's fiscal year end, there's a delay in getting the June reports. The month-end closing process is delayed. Typically, that wouldn't be a problem. However, there were a couple of hiccups this year coming from the SEO. The reports were not available until the day that the reports were due to Jill to be included in the board packets. I anticipate no changes, but I wanted to reserve an opportunity to be able to do a more thorough review of the financial reports. That being said, let's go ahead and start with our cash history. Okay, I see everybody can see the screen. So the ending cash balance for June was $3,389,700. That's a decrease of $858,600 compared to June of 2019. Remember that in August of 2019, we made a $935,000 principal payment. So that would be reflected in that $858,000. Before taking out board committed funds and program restricted funds, we have an average months in reserve of 3.22%. If we take out board committed funds of $316,200 and program restricted funds of $236,200, that brings us down to an estimated amount, or estimated reserves of 2.69. Are there any questions on cash balances before we look at the budget to actual? I take silence as no, so we will move on to the budget to actual. And what you'll see here is a consolidated version of the budget to actual. We don't have the line item detail that we typically see. I can provide that at a later date. We're going to look at our total revenue. We ended the year at $12,305,000 compared to a budgeted amount of $12,413,000. Under budget by $108,000. As we've previously discussed, COVID-19 affected our fees greatly. At the end of the fiscal year, environmental did and over budget. However, clinical and home health were under budget in revenues. Our personnel expenses were $8,411,000 compared to the budgeted amount of $8,904,000. So we were under budget by $493,500. We previously have discussed why we've been under budget. A lot of it has to do with we had a number of programs that had vacancies for an extended period of time, and we had several individuals, long-term employees, who retired, and when and if those positions were refilled, they were brought in at a lower rate. Total operating expense for the end of the year was $2,751,600 compared to a budgeted amount of $3,205,000. We were under budget by $453,500. Again, COVID plays into this because we couldn't, home health, they couldn't have contractors, physical therapists come in, see clients because we simply didn't have the clients at that time. Professional services, for example, the CARES program, we couldn't have or refer people to colonoscopies, so we didn't have the physician fees there. Those are just a couple of examples of how COVID played into that, as well as the fact that our employees weren't traveling, so we didn't incur travel cost. Capital expenditures, we ended at $1,457,500 compared to a budgeted amount of $1,418,000. So we were over budget by $39,000. That over budget amount actually represents some equipment that was purchased for COVID, for the COVID response, and that will be reimbursed by one of the funding sources. Total trustee benefit and payments, we ended at $30,000 compared to a budgeted amount of $38,000, under budget by $7,800. As we've discussed before, that one's difficult to budget and anticipate what the actual expenses will be through the year. So total expenditures for fiscal year 20 ended at $12,650,000 compared to a budgeted amount of $13,565,956. We were under budget by $915,621. So the deficit, we had a deficit of $345,000. Once we adjust for the increase in accounts receivable of $513,000, add back our beginning cash balance for the year of $4.2 million, it brings us back to our ending cash of $3,389,709. Are there any questions? If there are no questions, this concludes my board report.
Well, Christine, you're doing good. And I know this has been a difficult time the last 4 months or so, not knowing just what direction some of these line items were going to go, but thank you for keeping up and appreciate your work.
Thank you, Marlo. I appreciate that.
Okay, that if there are no comments or questions, that would conclude this item on our agenda, item number 7. Then we go to item number 8, the election of officers, which we do annually at this time for a chair, a vice chair, and a trustee. What is your pleasure?
Mr. Chairman, I would nominate yourself to continue as chair, but I haven't talked to you personally about that. Is that something that you desire to do?
What an appropriate time to ask me. Sure.
I would second the motion.
All right, all in favor of continuing the same chair indicate by saying aye.
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 Opposed, no. Vice Chair, currently Walt Kirby. What is your pleasure?
Is Walt still on the line?
I think Walt, yeah, I think he is not on the line anymore. Okay,
And I'll tell you why. Walt is retiring at the end of this year.
yes.
And will no longer be a Boundary County Commissioner. I'm sure that Boundary County will come somewhere else. Just anticipating what's going to happen.
Mr. Chairman, might I?
Sure, see if you,
So what we're at the election of officers, and Marlo's been elected as chair and accepted that. Alan has nominated Mr. Bailey as vice chair, only because you have verbalized that you're going to leave us after or that, I mean, you're not running again as commissioner.
That's true.
So we have a motion and a second on the floor. Who was the second? Michael. Oh, thank you.
all right, we have a motion seconded that Glenn Bailey be elected as vice chair. All in favor indicate by saying aye.
Aye.
Opposed, no. All right. Mr. Bailey, you have been elected vice chair, and now the trustee position.
I think Glenn does an awesome job as a trustee, and I would make a motion that Glenn Bailey is retained as our trustee.
Second.
All right, moved and seconded that Glenn, you continue as trustee. Is that okay with you?
I would add that I really, we all appreciate your doing the hard work in that role. Idaho is crazy, and nice to have a clearer voice at the table.
Yes.
Yeah.
Yes, and you realize that this involves really a trustee, a lot more work than being chair. It really does. So all in favor then of Glenn continuing as our trustee indicate by saying aye.
Aye.
And opposed, no. And we have our officers elected for another year beginning July 1, and now the director's report.
Thank you, Mr. Chairman. And if you would allow, I do have, I have prepared, because I think it's important that, as I mentioned earlier, that we're all aware of what's going on in our counties as far as our COVID numbers. So Mr. Lee is prepared to, there's about 8 or 9 slides just to run through those. Jeff, are you able to do that, please?
Yes, ma'am, I am. Nick, could you make one, please?
They're up.
Yeah, I can't see much on the screen. Lovely shade of gold. There we go.
We see it, Jeff.
Okay, Jeff, we're good to go.
Okay, next slide, please. Okay, this table shows the case distribution as of 2 days ago by county. I've included the county's population, and the percentage that population is of the total of district population. Pardon me for getting redundant there. The case count by county, what proportion of all the cases those represent, and the incidence rate. This is just a few different ways to look at the disease burden on each of the counties. So in Benoit County, they represent almost 4% of the district population and only are accounting for about 3% of the disease activity. Bonner County is representing about 8% of disease activity and is almost 19% of the population. Boundary County is way down for a disease percentage. It's Kootenai County, though, that is representing a disproportionate amount of the disease with comparison to its portion of the population. And it's obviously got the highest incidence rate per 100,000. This is where we're seeing the majority of our cases occurring. And as I said, as you can see on the case count, the District 1 case count a couple days ago was just over 1,300 cases. I'm looking at the report that came out from our data entry folks, and we're now at 1,427 cases. So in just 2 days, we went up 127 cases. Next slide, please. This is showing age distribution for the counties, by county, using the median age. We have a pretty significant spread, you know, with some definite outliers. As you can see in Kootenai County, the youngest person to be infected is under the age of 12 months. And the oldest in Kootenai County is 96 years. The county without any children on the list yet is Shoshone County. Their youngest is 19 years and it goes up to 89 years of age. But the median ages are coming down. We're seeing a decrease from the higher to mid-40s down to mid-40s down into less than 30 for the median age as younger people. And this was not unexpected as the quarantine, the self-isolation rules were relaxed and bars and restaurants opened, and a lot of the cases we're getting are represented by younger individuals that are bringing that median age down. Next slide, please.
Mr. Chairman?
Yes.
Can I interject one question here? You're still calling cases positive tests, is that correct?
I'm sorry.
Positive test for COVID-19 using the PCR test is the basis of you calling it a case, is that right?
It's not me calling it a case, sir. It's the CDC.
So you're not calling it a case?
The Council of State and Territorial Epidemiologists. I follow what they say.
Okay, so in other words, you are calling a positive test a case? Was that a yes or a no?
It's a case, sir.
All right, thank you.
The positive lab is a case.
If I could, Mr. Chair, just to help.
I can certainly read the language of that for you if you'd like.
Just a moment, Jeff, Dr. McLandris has a comment.
Just want to dive into this, but to bottom line it, the false positive for the RC-PCR is way less than 80%. Some are saying they're pulling them off the market if they're 3% false positive. So that's just a little bit of background. There's more to study on this. So I didn't mean to interject, but I think it's important to know that evolving knowledge about false positives. Thanks.
All right, go ahead, Jeff.
Okay, sir. Next slide, please. This is the, oh, I'm sorry. Could you go back one slide or two? Where are we at? Yeah, we went forward too far. Okay. Next slide, please. Okay, evidently those slides were removed. Okay. I'm sorry. This is the cumulative count for our COVID cases since March 15th. It looks a lot like the diagram you saw last week, and it looks a lot like diagrams we're seeing around the country, moving into that exponential curve. But we're now up, well, we're going to be up above 1,400 the next time we print this out. So it's continuing to trend up. We're not seeing any indication that it's slowing down. And we'll just have to buckle up and take the ride. Next slide, please. Nick? Okay, thank you.
Can I ask a question on that last slide, please?
Okay.
Pardon me?
Dr. Banks has a question for you, Jeff.
Yes.
Yeah, on that last slide, we see the number of positive tests increasing. Were the number of tests performed proportionally increased as well?
No, sir. Those were the slides that were removed. Sorry about that. What that was showing was the positivity rate of the testing that's been occurring through the 2207 building at Kootenai Health, and it is showing increased positivity over time. So if increased testing were the cause of increased number of positives, we would expect that positivity rate to be stable, not change. It would still be the same proportion regardless of how many tests you do. But given the fact that you've increased the number of tests and the number of positives continues to increase in proportion to the number of tests, what we're seeing is an increase in spread of COVID-19 in the area.
Okay,
I'm not sure
one
I follow
moment,
that.
Jeff. First off, Joe, were you trying to communicate something?
I think you're speaking of two separate slides. Okay, I believe Dr. Banks was asking about this slide, which is the ski slope that shows total cumulative cases, and Jeff was explaining this slide. So that's why there seems to be...
All right. Okay. Now we're on the same page.
Okay, then Glenn, did you have your hand up?
Yes, Mr. Chairman, my question is, what's the definition of frequency on this slide?
Okay, did you get that?
Frequency is how often something occurs. So in this case, if you travel, I apologize, I don't have a pointer that I can use there, but if you follow the orange or gold lines, you can see where it changes shape. There's peaks, there's troughs. Those are indicating a number, how many cases came in that day. That's frequency. One day it could be 5, the next day it could be 10, another day it could be 7 cases. That is frequency. And as that has moved along, the frequency did drop off for a period there between mid-April to about the 24th of May, when we started loosening up through the stages. And then we started to see an increased frequency of cases coming in again, and that not only increased in the how often we were getting the tests in, but also in the amplitude of the number of tests that were coming in. And so you can see through this current week, there are, while the tests aren't as high as they were a few days ago, like I said, we're still passing 1,400 cases at this point. That is measured, the orange line is measured along the left y-axis, the case frequency. The blue line is measured along the right, or running average. And what that's telling us is, if we smoothed out all the cases that we've gotten over the entire course since the 15th of March, at any given point, if we look at, say, just the middle part of the graph there, that was about 4 cases per day on average that were coming in. And that has quadrupled now. If we evened out this whole thing out over those 4 months or so, it would be 16 cases a day. It's just a method of comparing activity.
Okay, and for further clarification, Jeff, are these active cases, people that are showing symptoms, or are these total cases?
They're cases. I'm not sure. Are you asking if they're symptomatic versus asymptomatic?
Yes.
Okay. Not everybody has had symptoms at time of intake, although they did develop symptoms later. Some people have not had symptoms throughout the course of the time period for the illness, but they had tested positive. And others have been quite sick through the course of their illness. What we're being told from the...
Graphing that, are you charting severity of the illness at all? By age?
No, sir. No, sir.
Okay, thank you.
Next slide, Nick.
This is the epi curve based on when we received a case. There's delay from the time that somebody may have been infected to the time that they seek testing, and then from the time that they've been tested to the time the result has been turned into us. That creates a little bit of a lag, and so sometimes the tests pile up on one day. They may not have all been collected on the same day, but they tend to come in. But that doesn't account for the significant increase. And these are only positive tests. These aren't representative of all the tests that were done. These are just the positive tests that are coming in. And we're seeing a significant number, also indicating, along with the positivity rate, that we have a lot of circulation of COVID-19 in the area. And the next slide is just to help demonstrate that delay. You can see on this slide that this is the date of test for all the cases that we've had reported to us. And it's much more bunched up. It's not quite as spread out. The tests were all done. And if you see some faint lines in there, between the red lines, those are weekends. They haven't been doing testing on the weekends. Next slide, please. Here we go. This is the Kootenai Health testing. It shows the cumulative positivity rate over time, regardless of the quantity of testing done. This is simply how many tests, as a proportion of all tests, were positive. And as you can see, there is a progressive increase in that positivity rate.
Mr. Chairman?
Yes.
Thank you, Jeff. So what my intent to do with you is to assure that you've got the data that we've got, and assure that we're displaying it in a way that is meaningful to you. Mr. Ness referenced the Eastern Idaho's plan. I forwarded that to you a bit ago, I believe. I don't know that that fits this region, but I certainly am prepared to present a draft plan with your input as staff and I create it for you to consider. You know, what I would like to do and what I think is sensical is let's see what happens with the order that was put into place today. Are we going to see because as we've spoken about in the past, the cases or the positive tests we see today are a result of behaviors a week and a half to 2 weeks ago. So where are we going to be a week and a half from 2 weeks to now? Are we going to see a little bit of a lessening of the trajectory, most especially in Kootenai County that we're seeing now? So I certainly would ask you, would you like me to work on putting together a plan that goes county by county and looks at different benchmarks? This is what the Eastern Idaho, both of those districts did. And I'm happy to forward you both of those plans from District 6 and 7, and District 4 also has one. They use some different parameters, different benchmarks, similar to what Governor Little used in his plan. So that up for your consideration. And the other thing I would ask is, how frequently would you like to meet? I think this is, I think it's imperative that we meet with a little bit more frequency, perhaps not weekly as we have been the last 3 weeks, but I put that to you. How often would you like to meet as a board? Understanding that there is quite a bit of public interest in our meetings.
Dr. McLeod, respecting all the lack of knowledge that we have, and we need to learn as we go, that to develop a report to us every week, I do think we need to address the meeting to decide if we need to roll back the mandate.
Mm-hmm.
And so, should we meet every 2 weeks? Should we meet every 4 weeks? I don't know the answer. I'm happy to meet as often as you think that we should. I do think collaborative effort in the community with Kootenai Health, especially to create a plan, is really important to feed that back to us and let us have input, for sure.
Right, because that's truly what it is. As I suggested before, it's about their capacity, and you know, should they have to cancel electives, that type of thing, and that they would be in their highest level, or their level 4, were they back there, and they're not there right now. But certainly, I mean, I serve at your pleasure. I'd be happy to meet as frequently as you would like. I don't know that we can get this room, so we would have to figure that out, but I think that we've got a lot of expertise in our staff, our planning staff, and Mr. Rigello there.
You're talking about our monthly meeting?
Right, how frequently? We have no meeting date in August.
Well,
Would you like to meet again in 2 weeks, 3 weeks, 4 weeks?
I would suggest our next regular meeting would be in September.
Right, but I would suggest we meet regularly before that.
But the next meeting, if we just took the same last Thursday of the month, would be August 27, I believe. And it would seem like, based on what's going on right now, it might be wise to schedule a meeting for August 27 and then go on then to our regular September meeting. And at that point, we can decide whether we need to continue monthly meetings or whether we can go every 2 months.
Based on the trending,
yeah. So if I'm hearing the board, our next meeting will be 27 August. If something should come up prior to that, I really don't want to call a special meeting, but rather a regular meeting with the proper notice. If I need to do that, I will be in touch with the chair and we would meet prior to 27 August, should the need arise.
And I would say plan to meet at our regular board room or at least in the room downstairs. Yes, Joe?
Unless the dynamic changes from what's existing in the parking lot right now and on social media, I would not recommend meeting in our facility.
You would not recommend what?
Meeting in our facilities, as long
Really?
as the orders in place in this situation. Sir, there's quite a large number of people who are quite displeased right now. And I will address that at the end by giving instructions about how we're going to get you guys back to your vehicles. But, there's a SWAT team waiting in the hallway to keep the crowd outside in order to get along. I just want to set the reality.
Okay, well,
It may not be business as usual.
you know what? There are times when people disappoint me.
Got some hotheads, yep.
And I told them all along, even we as a board don't always agree. Okay. Our next regular meeting will be August 27. And I don't know that we need to decide right now location, do we?
To be determined.
Yeah.
The most,
Yes.
Chairman, the most time that the director and the staff can get the plan would be the best. So, you know, I would like to look at where we think it's appropriate to put the meeting and set, so we can start doing that planning. We put all of this together in less than a week, but I don't know that we can.
Yeah, okay. Let's just say we plan to have a meeting August 27. Does that cover it?
Yes.
Any other business then to come before this board? Anything else? Glenn?
Yes, Mr. Chairman, and I'll keep beating a dead horse. This format is much easier for me to comprehend and to understand. I would like to see, I don't know that it'd be that hard.
We're working on it.
Create a slide that shows county by county, today's cases, active cases, recovered cases, total deaths, death rate, average age of death. That could be broken down. It wouldn't be that difficult.
Right. It's the hospital beds were the piece that we're working on, but.
The hospital changed, Kootenai changed the way they're doing it. It's much more readable.
Good.
It's much more readable, so there's a way to make it readable. I'm sure our
Yeah.
Right, yeah, we'll.
try to figure out a way to.
We're working.
Track the total hospital beds and then break that down to ICU beds and their occupancy.
Well,
Yeah.
I would,
That'd be useful.
the governor's office has to be doing this because if this keeps going this way, we are out to lunch. We will see the state closed. So they're keeping stats.
They are, but we're, you know, we truly, I mean, if you look at the reality of what's going on with our staff, I mean, they are beyond maxed out. But we are looking at this data. There was something in the newspaper today that was, I'm not sure, I was trying to get who published it. I don't know if it was it was Bully had it, and it had some of that data, not all of it. But yes, Mr. Bailey, we will, I'm working on it.
Thank you. Useful information.
Well, I would just like to say to you folks, thank you for putting up with me and all of my blunders. This type of behavior, I will confess to you, surprises me. I give people, I guess, more credit than I ought. And frankly, I loved it when they all talked at once because that way I didn't have to listen to any one person.
You're doing a good job, Arnold. Thank you.
Well, as far as those two ladies over here that claimed I said right at the beginning I was going to choose at random, and maybe I should have had a better understanding with Joe that I would pick them in order that he gave them to me, but that's not foolproof.
Worked out great, luckily, so far.
But you say out in the parking lot, is that what he's?
Yeah, why don't we should adjourn the meeting?
All right, we're adjourned. Sorry.
And